I'm going to talk to you about clinical record keeping, and then I'm going to go on to tell you a little bit more about Asira and how that's going to help you with your clinical record keeping. Okay? So if we begin by the benefits of clinical record keeping, like why do we want to maintain good clinical records? First of all, to retain clinical information. So for example, the patient came today, you did XYZ number of tests. Now you decide you need to do XYZ more tests, but the patient doesn't have time today. So you're going to call them back. But they're going to come back after 3 months. You're not going to remember the patient's name, nor their face, nor anything about them by the time they've come back, or anything you did. So if you have a very clear record of what you did, everything documented correctly, it'll be very, very easy for you. And the patient will feel really happy because they'll be like, oh, this practitioner knows me. Okay. Secondly, when you are referring to other practitioners, whether it is an ophthalmologist or whether it's an optometrist who practices a different disciplinary to you do, it's very, very useful to just be able to give a well-documented report, send it directly to the other practitioner. They will really appreciate it because they'll exactly be able to see what is done, what is not done, what was the outcome, and what do they have to do next. So what else? Practitioner protection. Now that the laws are changing, okay, have changed rather, and optometry has become more regulated, this is going to affect you in many ways. You can't just do anything now. You will have to follow your best practice guidelines very specifically, which means that you will be held accountable and held responsible, which you should, okay? So there may be times when there might be complaints against you and there might be legal proceedings against you. This is a very real situation, okay? Having said that, if you have maintained very, very solid clinical records, it is your word against theirs in a court of law. So it's very, very important to protect yourself, to protect your practice, and to protect your patients as well. Now, a lot of us in the future will like to participate in clinical research, or you might apply to fellowships, or you might also just want to do any kind of retrospective studies. If you have a very, very nice set of case records, you can pick and choose whatever you want. You can easily look at very, very, very historical data. I'm actually applying for the fellowship for BCLA this year, and I have patient data from like 12 years ago when I first moved to India, and I can track that patient all the way and present that case. So it's really, really useful for that. Also, one thing, which is an entire separate topic, so I'm not going to go into detail, is to do clinical audits, which means you get another practitioner equally or more qualified than you are to come into your practice and look at your records and to criticize them, okay? Not in a horrible way like your records are terrible, you shouldn't practice anymore. No, but to say you may have missed this, you may have missed this. Clinical audits are very, very, very useful. I have an ophthalmologist, a very sweet old retired gentleman who comes in and does my clinical audits, and it's really, really very useful because it just makes you see things in a new light. Again, if you have good clinical records, it's really helpful with that. So now, how do we write records? What is the best way of documentation? Okay, so the best way is something called SOAP documentation. This is a globally recognized and validated form of documentation, whether it's for case records, whether it's for just normal day-to-day record keeping, or whether it's for case presentations, whatever you're using it for, okay? So it was introduced at Yale University many, many years ago, and it falls under problem-oriented medical record keeping. So back in the day where, I'm talking way, way back in the day, before all of our times, the patient would come in, they'd do a quick examination, and they'd give medication. Things have changed now. We do a much more detailed history. We do much more detailed examinations. And we do the examinations based on the problem. That's why it's called problem-oriented, okay? So, and it is a very systematic approach that helps in documentation and clinical decision-making. So what does it stand for? S for subjective, O for objective, A for assessment, P for plan, and E. E is an extra thing that recently practitioners have included. Stands for education. We're going to go through those one by one, okay? So how does this apply to you in your daily practice as optometrists? How do we apply SOAP? So number one, your subjective section of SOAP would be referring to your history taking. That is the first and foremost, most important thing you should do. A lot of the times, you take a good history and you can reach at least 3 to 4 provisional diagnoses without even having to do the next part of the examination. So good history will take you very, very far. Okay, then that would include the chief complaints. When we take a history, we always go from the most recent history to the most furthest history, okay? So chief complaint, recent history is what is happening today. Why are you here today, okay? Then we go further back, ocular history, any infections, previous surgery, previous trauma, anything like that. Have they been diagnosed with any conditions, glaucoma, ARMD, whatever. Systemic history, have they been diagnosed with, of course, diabetes, the most important one, but lots of other things, hypertension, arthritis, asthma, allergies. There's lots and lots of things that we ask for. Family history, we know things like myopia, for example. The genetic factor is a major one. And there's diabetes as well, lots of other things. And of course, we ask about hobbies and lifestyle, including their occupation, because the way we manage the patient will depend on that. Okay, so these are all the things we want to document. This is the basics that we want to document, okay? Then with the objective section of SOAP is your tests. So which tests are you doing? These are your basic. Now, you just attended the best practice lecture, okay? So you're very clear on what tests you're supposed to do. Your vision, visual acuity, subjective, objective refraction, basic binocular vision function. I believe, as does OCI, that basic BV function should be done on everybody, okay? Which was covered, I'm not going to go into detail, it was covered before. Of course, the basic anterior and posterior segment evaluation. You all have slit lamps, you all have ophthalmoscopes, okay? And some of you may have Volk lenses. I like using Volk lenses. So it depends on what your preference is, but look at the macula, look at the optic disc, have a quick look at the peripheral retina, and document, okay? Documenting it all nicely. Okay, IOP measurement, if it's necessary, if we feel it's necessary, done especially with people over the age of 40, and a lot of people have autorefractors with NCT, non-contact tonometers in them, so please use those. Okay, so assessment is, now you've done all your tests, okay, and what do you do with that? So you're going to assess your results and come up with either a final diagnosis or a differential diagnosis, okay? And you're going to identify at every step, at every test you did, what is the problem, how does it lie in, how does it relate to your subjective section, and you're going to reach a diagnosis, and this is everything that you're going to document, okay? Then, now you've done everything, you've reached an answer, but this, I believe, is the most important part of your examination. The management, you've finally done everything, but what are you going to do next? Are you going to manage the patient yourself? Okay. Are you going to do any kind of specialist referral? Are you going to refer to a colleague, to a surgeon, anything like that? And if you're going to refer, if you're not referring, so if you're referring, then of course you must document it very, very clearly. And if you're doing anything, if you're managing it yourself, you must document the therapy and the treatment prescribed. Okay? Next thing is your patient education. Also very, very important. You can't just write stuff down and let the patient go. The patient wants to know. The patient wants to know, what have you found? What is wrong with me, and what are you doing to solve the problem? It's very, very important to talk to the patient. Now, when Vandana was talking about referral before, she said that if you are good and if you do your job well, they will always come back. This area, you take another 10 minutes just to have a chat with the patient and to document everything that you've told them. Patient will be happy because they know exactly what's wrong with them. They know exactly what you're doing. When you've documented it clearly and you've given your patient instructions and you've given them written instructions and documented, there is no chance for any doubt. Okay? Everybody's clear about the plan. You are clear, the patient is clear. Okay? And it's always useful to give them written instructions and keep written instructions for yourself. So that would include details of the eye condition. What are you doing? Further testing or referral? What is the correction? Is it just spectacles or contact lenses, or do they need some vision therapy? What is it? And most importantly, when do you want them to come back? You must stress on that. I do want to see you again. You're not done forever, you know? So you need to come back once a year. As we all know, a lot of eye-related issues are asymptomatic. Okay, so big part of what we do as optometrists is screening. Okay, so it's very, very important that you tell the patient, this is when I want you to come back. And document it on your record that the follow-up for this patient is this. Okay, so now what I want to do is spend a couple of minutes just sharing with you a case and how I use SOAP documentation in my practice. So this was a case from my practice, 78-year-old female, and this was the history and symptoms. She came gradually deteriorating vision in the left eye since the last 6 months. She's only ever worn spectacles for reading, but lately she can read quite well without her spectacles also. General health is good, even though she's elderly, she's in good health, she's not on any medications, and drives, she's always driven her whole life, but she drives only during the day because the glare from oncoming traffic really disturbs her at night, okay? So this is your relevant history. So, objective, what tests have I done? Unaided vision, you can see what's written there, and a refraction. Now in the refraction you can see the left eye and you can see that there's no improvement with pinhole. So as you're doing the tests, you're documenting, these are all things you could keep a mental note of. This is not ordinary, this is not ordinary. And when you go back, you can look at everything and look through what you've documented and make sure you've not missed anything. So your binocular vision function was normal. You can see I've recorded all the tests. Anterior and posterior segment evaluation. Everything was unremarkable. Normally, in my patient records, I do a much more detailed, even if there is no problem, it's important to document that there is no problem rather than just leaving it blank. But for the sake of this presentation, I've only included relevant data. So unremarkable for both eyes, except for the following image of the left eye. Now, you've all seen this image before, but this is an image that I took of this patient in my practice. Okay? Now, sidebar. Okay? I love grading scales. Okay? Grading scales work really well for me, and they're very, very useful for documentation. Okay? So say you don't have a camera, or you're not so good at taking the photos. I'll be honest, my hand's a little bit shaky. I get my optom to take a lot of these photos because, you know, she's much better at it. So I like to use grading scales because it is validated and it is the same across the board. So I know what a grade 1 looks like or a grade 3 looks like. That patient moves to Bangalore, I send that patient to Ajay, and I've written grade 3, he's going to know what grade 3 is as well. Okay, and he's going to know, has it changed, has it not changed, since grade 3, which I saw last time. Okay, so grading scales, here on the left-hand side is your Brian Holden Vision Institute grading scale. This is one of my favorites, which I use for contact lenses very often. And this is a grading scale I really like to use for cataracts. We see so many cataract patients. A lot of elderly patients may have some cataract. For monitoring those cataracts, the grading scales are really, really fantastic, okay? Because then you can actually see, has it gotten worse and how much worse has it gotten? So coming back to the patient, this is how I use the grading scale. This picture on your left-hand side is the picture that I took, and I'm going to take it and compare it to my LOX grading scale, and as you can see, it's very clearly indicated N05, NC5. So my LOX grading would be documented as N05, NC5. Okay, so when I refer this to my ophthalmologist, which I did, but I'll come to that in a second. So the diagnosis, We all know it's a nuclear sclerosis cataract in the left eye, okay, and the grading. Now, how did I reach that, okay? I documented everything along the way according to my SOAP documentation. So I'm going to go back, okay? My subjective, my S. So what was the subjective findings to support this diagnosis? Number one was reduced distance vision in the left eye. That we know was there. And reports of glare. Glare, we all know, is a very common symptom for cataracts, okay? Then, what was my objective findings to support this diagnosis? Reduced unaided and reduced BCVA in the left eye and no improvement with pinhole. There was a myopic shift in the left eye and the observation, of course, under the slit lamp, you can very clearly see the nuclear sclerosis cataract. But as you can see, I looked through all my documented data to make sure I have used all of this to support the evidence. Okay, now, what is my plan? As an optometrist, can I do cataract surgery on this patient? No, okay? So what am I going to do? I'm going to refer it to the ophthalmologist for cataract evaluation, okay? How urgent? It's not that urgent because it's not sort of a hyper mature cataract that needs to be extracted immediately, so I'm going to refer it, you know, as long as they see the patient within 3 months, they see the opthal within 3 months, they should be fine. What am I going to send? So what did I do? I sent a referral letter covering all the information that I documented, that I've sent you, all the relevant information, electronically to the ophthalmologist with the patient's consent, okay? Don't forget, with the patient's consent. You cannot share their data without their consent. But of course, the patient knew I was doing it. So I said, would you like me to give you a printout of the document, or would you like me to send it directly to the ophthalmologist? And they, of course, chose to send it directly to the ophthalmologist because who wants to carry around paper, okay? You can also, of course, send copies of this to your patient as well. They should also have a copy of the referral letter if they want it. Now, what did I tell the patient? What was my communication? The E, I find that it's not in the original SOAP acronym, but I find it to be a very, very important part of patient education. Patient management is the counseling. What am I going to tell the patient? So here's what I told this patient, because cataract surgery, you and I all know it's very routine, okay? However, you tell any, especially an elderly patient, that they have to get surgery done, and it can be quite disconcerting for them, okay? So it's very important to communicate that and reassure. As an optometrist, you can really reassure this patient that cataract is a normal aging process of the eye. This is what I told my patient, told her a little bit about the prevalence and the type of cataract that she had. That's useful. Also, when you communicate these things to the patient, they feel more comfortable with you and they will come back to you. Phacoemulsification, told her a little bit about the process and told her how safe it is, that it's got a 99% success rate. Plus, as we saw from the documentation before, she's fairly healthy. She is elderly, but she's fairly healthy. She's not on any medications, no diabetes, so the chances of complications are much lower. So what else? The surgery is not urgent, but is necessary. So while she doesn't have to get it done tomorrow, she does have to get it done eventually. This is very important for me to document this because I don't want this patient coming back to me and said, but you said I don't need it. No, I said you don't need it today, okay? So this documentation is very, very important, okay? Why? And again, something that I would have explained to the patient to alleviate the symptoms and improve quality of life and, of course, avoid further complications. Okay, so now I'm going to move on to the second part of my presentation, which is I want to tell you a little bit more about Asera. So while we talk about all of this documentation, imagine doing all of this on paper, which I have been doing until very, very recently, okay? It's a lot of things to write, okay? And it's also challenging to look at the patient and talk to the patient and write things at the same time. It's an art form that takes many, many years to perfect, okay? So now, in this day and age, in 2023, we can go digital, okay? So let's talk a little bit about going digital. Now, what are the challenges of modern eye care practice? First of all, administration. All of you who are practice owners or work in practice know exactly how much admin is involved in terms of accounts, inventory, ordering, and managing appointments. So, if you have one appointment book and you have 4 practitioners, it can be a real pain because you're going to spend your whole life running around the practice searching for the appointment book, okay? Clinical records. Now, whoever is maintaining records, which you should be right now, you will have stacks and stacks and files and files and filing cabinets of clinical records, okay? And eventually, you will run out of space, okay? In further, how much time is spent? We spend at least an hour a day searching for all the clinical records. Then we spend another hour a day filing them back again in the right place so that we don't lose them. And of course, despite taking all these precautions, we still lose them. You still can't, occasionally you still can't find a clinical record. So now you don't know what to do with this patient. So let's get rid of all of that and just use a laptop or a tablet, okay? Making our life much easier, and of course it's better for the environment, saving paper. Now, why is record keeping necessary and electronic record keeping necessary? We have just talked about change in legislation in optometry, and we have talked about how you will be held accountable. So having solid records in a safe place where they are always accessible by you is very, very important, okay? Secondly, I'm seeing a lot of young people here in the back, and I know a lot of these young people, the optometrists of today, are much more clinically inclined, okay? So just the whole era of opticians is disappearing. Now people are doing much more clinical work, not just selling spectacles, doing much more clinical work within their practices, okay? So there's a lot more to document than just writing a spectacle prescription. So what's happening globally? Well, 99% of optometrists globally are using computers or tablets in their consulting room, okay? 80% use a practice management software, or PMS. A practice management software, it basically means something that helps you with your scheduling, your appointments, and your patient management. Only 50% are using electronic medical records. That means documenting your clinical data electronically, and only 10% are completely paperless. We want to be completely paperless. That would be the aim. No more writing, no more pen and paper. We want everything to be digital, okay? We did a survey here before we launched our product, before we started building our product, and we found that only 50% of eye care practitioners in India are digital. Only 50%. The rest are all still using paper records or no records. So I would like to introduce Asira, if it ever loads. Okay, there we go. So I would like to introduce Asira. So Asira is a practice management and EMR software, so everything in one place, designed by optometrists for optometrists like you guys. So what are the advantages of EMR and practice management software? You save time, definitely save a lot of time in looking for clinical records. It's you just type in the patient's name or the patient's mobile number and everything is there for you. You save space, you can get rid of all those filing cabinets and get yourself a new corneal topographer. You can access your records from anywhere, so I'm sure you all have experienced the patient calling you at 10 o'clock at night saying, I urgently need my contact lenses by tomorrow. So what you can do is immediately look up their records, sitting at home, and get that order in process immediately. No more lost records, improves inter-practitioner communication, as well as practitioner-patient communication, because you can automatically send everything digitally to the patient. It's safe and secure, so it's cloud-based, so it's safe and secure clinical record keeping. You can do inventory management, automation of spectacle and contact lens orders. A lot of people are still WhatsApping their orders to their contact lens suppliers or sending off written orders to their spectacle labs. So this can all be automated. Automation of patient reminders and recall. It's so nice when the patient receives a message saying that you're due for your appointment, or they receive a message saying your spectacles are ready, your contact lenses are ready. And of course, billing and accounts can be made much easier and faster. So I did a little bit more research as to why. Why is this number so low? Why only 50%? What are the barriers? Number one is cost. Of course, I did the research myself for my own practice, and a lot of things are unaffordable. It's very, very, very expensive. Then, of course, there's unfamiliarity with technology. Now, generally, across healthcare, I'm not talking about just optometry, across healthcare, people in the healthcare profession are not as technologically inclined as engineers, okay? It's just a fact of life. So when it comes to using technology, it can be a little bit daunting, okay? And of course, some of these softwares are very complicated and require a lot of training time, which then sort of works against you in your practice, where you end up spending more time learning how to use a lot of software and less time attending to your patients. Hand-drawn figures. When I've been presenting at all these conferences, first thing the practitioner said is, I like to draw diagrams, so what can you do about that? Lack of access to information, so it's very difficult to even find these softwares. Where are they? How do I access them? And of course, a big one, uncertainty about the security of their privileged information. So all your documentation, everything you're documenting is privileged. So there is uncertainty regarding that. So how are we breaking these barriers? Well, we have a unique pricing strategy for everybody, including single practitioners. The way that it has been designed is completely user-friendly. Nobody needs training for Facebook or Instagram. People just figure out how to use it. That's the idea here. You should just be able to start and go. Okay. We have integrated grading scales. We have very specifically designed drawing tools for eye care practitioners and optometrists. And of course, we are very, very easy to get in touch with because you can contact us through OCI. We have a blog. We're on social media. So it's really, really easy to find us. Okay, so the big one, how do you know your information is secure? Well, while we don't have, as of now, we will, it's in the making. We don't have specific data protection laws in India, but it will happen, I would think, within the next year or so. How have we done our compliance? We've based it on HIPAA, on SOX 2, GDPR, and the Data Protection Act in the UK. So we have used all of their guidelines to maintain our compliance. The software is powered by AWS, which is incredibly, incredibly difficult to hack. So it's very, very safe. The databases are encrypted. And we also allow role-based practice within your practice. So within your practice, you can, as an owner or as like the lead practitioner, you can decide who has access to what. Okay? So, our EMR. So because if anyone who knows me will know that I do everything evidence-based. That is a very, very important thing to me. So even while designing the EMR, everything is done following evidence-based protocols, and it ties in very nicely with the best practice standards, which are all listed on the OCI website. Okay? And of course, it follows the SOAP guidelines, so everything is completely systematic in that order. So just a couple of screenshots. As you can see, I just wanted to show you this, demonstrate the SOAP. So there's a page there's a very detailed history section. There's a very detailed vision and visual acuity section. I'm done, so I'm going to make this very, very quick. Anterior segment evaluation and your action and advice, which is very, very important. Okay, so this is a very nice paper published in the Indian Journal of Ophthalmology, which talks about the massive, massive advantages of EMR. So finally, we are here all day today. Please come and talk to us. Please come and visit our booth. come and do a demo. I'd really, really like to show you what we've built, and hopefully you guys can start using it in your practices. Thank you so much for your time.